It's a great pleasure to introduce Jordan Feld to give the next presentation. Firstly, it's great that Jordan's made it safely to the university campus. Yesterday, coming to the opening of the Kirby Institute in a taxi, he was given directions by Jason Greveley to come to the corner of Botany Street and High Street at the university, and ended up at the corner of Botany Road and Hay Street in Alexandria, several kilometres to the west for those not from Sydney. Jordan's a colleague and a close friend, and his clinical appointments at the Toronto Western Hospital as a gastrohepatologist. He's assistant professor at Toronto University in the Toronto Centre for Liver Disease and the Sandra Rotman Centre for Global Health. And I think in the setting of great sort of scientific leaders, Jordan has the capacity to place his scientific research, which is in innate immunity and hepatitis C, in the broader context of population health and global impact. And in keeping with that ability, he's presenting today on viral hepatitis. Will new therapies deliver global impact? Thanks very much, Jordan.
Thanks, Greg, and thank you, Professor Cooper, and the other organizers of today's symposium. It's really a great honor to be here, and I'm glad I was able to get here safely this morning to participate in this wonderful symposium. With really, it's truly a privilege to be speaking amongst some really outstanding speakers today. And I also do want to congratulate the Kirby on your new facility. It was great to be here yesterday and see the opening of this facility, and I, for one, can speak to the fact that the Kirby may have started as an HIV research organization, which was part of its name, but it's really spread its wings. And I can say that as I've been fortunate enough to collaborate with Greg and some other of the investigators at the Kirby, and can really speak to the fact that although this organization may have started in HIV and continues to be clearly a world leader in HIV and AIDS research, it is also absolutely a world leader in the area of viral hepatitis, and the contributions that the Kirby has and continues to make really stand out both nationally and internationally. And I'm going to speak to today some of the advances. I'm going to focus most of my comments on hepatitis C, but I will also talk about hepatitis B and how this area of bloodborne infections is rapidly changing. And I'm going to give you an overview of how some of these new therapies will hopefully lead to global impact. So I'm going to try to make three major points. First of all, that hepatitis B and hepatitis C cause an enormous, and I would argue sometimes under-recognized burden of disease. That there are new agents for both infections that will achieve control of disease in almost everyone with hepatitis B infection and cure for almost all of those infected with hepatitis C virus. And finally, that eradication requires a lot more than good drugs. So if we start with the first point, just some high-level sobering facts about hepatitis B infection. This is really a global public health problem with about 400 million people chronically infected and somewhere close to a third of the world's population exposed to the virus at some point. And just to give you a context of what that causes in terms of disease burden, somewhere between 600,000 and 1 million people die of hepatitis B-related complications, either from liver failure or, more importantly, liver cancer, and that's really comparable to malaria in terms of its total burden. And when you look at here in this map showing you the epidemiology, you see that the burden is largely in middle and low-income countries, particularly sub-Saharan Africa and East Asia, where you see the dark green high prevalence regions, and you'll also notice that in indigenous populations, particularly in the far north of Canada, this is also a problem. But I also point out that actually places like Toronto, and I'm sure I could add Sydney and Melbourne to this list, fall into areas of intermediate prevalence, and this is because of the large foreign-born populations and the massive globalization that this involves, meaning that these are not, and I'll show you data to support this, that these are not simply problems in developing countries. Now, hepatitis C, of course, is also a major global public health problem with somewhere between 130 and 170 million people chronically infected with this. There's no vaccine for this infection, and it is currently the leading indication for liver transplantation. Again, here you see the epidemiology, and again, once you see there are some differences here, but again, the burden of the illness in terms of prevalence, those red countries, highlighting the very high prevalence countries, tend to be in particularly low and to some degree middle income countries. Now I'm going to focus next comment's on burden, mostly on hepatitis C. So this is the potential consequence of hepatitis C. You start out with a healthy liver, and you have slow progression with the possibility of fibrosis progressing to cirrhosis, and in some of those patients developing liver cancer. And what I've put here is the number that is usually quoted of 20% of people developing cirrhosis. And so the problem with this is that the implication of that is that 80% of people with this infection don't develop any consequences of their disease. But this is in fact wrong, because what's not shown here is that that's 20% at 20 years of infection. And that's a very important point, because most people acquire this infection at a young age, some either through vertical or early exposure as a young child in their countries of origin, and many people through injection drug use, often in their teens and 20s, meaning that people have this infection for often decades and decades of infection. And when you look at longer durations of infection, you start to see marked increased rates in the rates of cirrhosis. So by 30 years, approximately 40% of people have progressed to cirrhosis, and the lifetime risk is probably upwards of 50 or 60%, meaning that there's a huge toll from this. And it's important to remember this, because that number of 20% unfortunately permeates the literature and would lead to the implication that most people with this infection don't have a problem. Now, the consequence of this is that over time, as the population ages and they've had the infection longer, you start to see the consequences accumulate. So this is data from the US with a projection that by the year 2020, 37% of those with HCV infection in the US will have progressed to cirrhosis. And it's only once people develop cirrhosis that they start to develop the complications of the disease. And so what I'll show you is that the consequences of the disease differ somewhat depending on the epidemiology in the region. So here are 4 different curves, and they demonstrate in the graph on the right, you see the HCV prevalence in these countries, the USA, Australia, Japan, and Egypt. And then on the left, you see the burden of HCV-related liver disease in these populations. And so if you look at the USA and Australia, these are somewhat similar epidemics where they have a relatively low overall prevalence. The transmission is largely through injection drug use, and those with infection, many of whom are no longer using injection drugs, actually pose a low transmission risk. But you can see that as the population ages and people have had the infection for a long time, the burden of illness starts to accumulate with increasing numbers shown over here as people have had the infection a long time. In contrast, if you compare that to Japan, which is a country that also has a relatively low prevalence, but it's an older aged cohort, so that you see that in this population of older patients, the prevalence is quite high, whereas in the younger population, it's quite low. And the consequence of that is that the Japanese epidemic has led to much greater liver-related complications because of the older age of the population. This was largely an iatrogenic related to blood transfusions many years ago, and transmission remains low. And finally, if you look at Egypt, which has the highest prevalence in the world, this is a country where most of the spread of disease is iatrogenic through misuse of dirty medical equipment. And because of this very high prevalence, this also leads to high ongoing rates of transmission, and this also leads to a very high and increasing burden of disease as the population ages. And so it's important to think about these things when you compare the epidemiology between different populations. And so now if you look at the different countries and you think about them in terms of low, middle, and high income countries, what you see is that prevalence doesn't actually tell the whole story. So this looks at not just the prevalence, but the absolute numbers. And what stands out here is that actually Asia, China, and India, which in truth have relatively low prevalence, have a huge burden of absolute infections, and that compares to a country like Egypt, which has a staggering prevalence of close to 20% in some populations, with a much lower overall burden of infection. And so if you contrast this to HIV and hepatitis B, the highest prevalence still in Africa, in Egypt, but the largest absolute numbers are in Asia, and the burden is greatest in lower and middle income countries. You see that along this list, most of these countries are low and middle income countries, with the US popping up here, and really no other high income countries making this list. So, but I want to make the point that this is not only a problem in developing countries. So this is a study that was done in Canada. It's called the Ontario Burden of Infectious Disease Study. And what they did is they looked at what infectious disease causes the greatest burden of illness in terms of total years of life lost and year equivalents of reduced function. And what you see here is topping the list, actually, which was a surprise to us. This was done by epidemiologists, not by hepatologists trying to get our next grant. And what we see is that hepatitis C actually tops the list, causing the greatest health burden in Ontario and likely in Canada. And if you look, hepatitis B pops up as 4th on the list, and if you put the two of these things together, the viral hepatitis, a huge burden of illness in Canada, a fairly wealthy country, and just to contrast that to HIV, and by no means to say HIV is not important, but this just shows you that at least in currently, because of the great progress that Dr. Cooper just showed you about, HIV is actually causing less burden than hepatitis C and hepatitis B. And this is seen similarly in the US with this landmark publication in the Annals of Internal Medicine a few years ago, which showed that as HIV survival has improved, unfortunately the burden from hepatitis C-related illness has increased over time and has actually surpassed HIV as a cause of mortality in the United States, with hepatitis B staying relatively stable over time. So summarizing point 1, both hepatitis B and C cause a large burden of illness from cirrhosis and liver failure as well as liver cancer. The global burden is greatest in developing countries, but there's an increasing burden in middle and high-income countries, and the burden increases markedly as the population ages. So then the next point, let's look at the therapies. So for hepatitis B, there are two approaches, either immunotherapy using interferon or direct antivirals, most of which we have been benefited from the advances in the HIV field, where the polymerase from hepatitis B can be inhibited by most of the HIV polymerase inhibitors. And so this is really a landmark study, which is one of the only studies, randomized studies, to show a clear survival benefit in patients who were given lamivudine or 3TC, one of the first antiretroviral agents for HIV that also works against hepatitis B. And you can see in these patients who started out with advanced liver disease, you can see that those that were randomized to drug had a better overall survival than those that received placebo. And subsequent development has led to more potent drugs that have a much lower likelihood of the emergence of resistance. And this is a study showing tenofovir, again an HIV drug, but unlike in HIV, tenofovir has a very high barrier to resistance with hepatitis B, and patients can be maintained on long-term tenofovir monotherapy without the emergence of antiviral resistance. And you can see in these patients treated for 5 years, they have very high rates of hepatitis B suppression, remain undetectable with no emergence of resistance. And if you look at comparing different classes of drugs, most of them now, if we really focus on the high-potency drugs like entecavir and tenofovir, you can see that most patients can achieve undetectable hepatitis B levels by a year of therapy, so this looks very promising. But the problem is, if you look at actually the surface antigen clearage rates, which are effectively the cure or end of clinical disease related to hepatitis B, the rates are extremely low at 1 year, and unfortunately they don't really increase with time. So the majority of patients need to stay on these therapies either lifelong or at least for many, many years. And so the problem is that we really still lack a cure. We're able to control hepatitis B in most patients, but cure has remained an elusive problem to date. Now, on hepatitis C front, things look a little bit different. This is the progress of therapy over time, and I'm not going to show you a picture of me 30 years ago like Dr. Cooper did, but this summarizes the progress of therapy over a similar time frame. And you can see when interferon monotherapy was used, you can see that the sustained virological response rates, which I'll explain in a moment, were very low at just 6%. With the addition of ribavirin, that was a major jump, going up to 34% and 42% if you extended therapy to a year. And then with a long-acting pegylated form of interferon, we finally broke the 50% barrier mark. So what is SVR? Why do we use this term SVR rather than cure? This has been a bit of a debate in the field, and what this is to show you is that SVR really is a cure. So SVR is defined as being virus undetectable in the blood previously 6 and now 3 months after finishing antiviral therapy. And what you can see is that patients followed for many, many years, whether HCV mono-infected or co-infected with HIV, they remain Hep C virus undetectable off therapy years after completing it. So this really is a durable endpoint, and it is in fact a virological cure. The rate of late relapse is much under 1%. So importantly, this is a virological cure, but what happens in terms of clinical outcomes? And this is a study that we participated in a number of years ago, which looks at what happens if you cure patients' hepatitis C infection in terms of their overall survival. So you can see their survival is excellent over 10 years, with very few having liver decompensation or developing liver cancer. And in fact, it's actually similar to an age-matched general population. So if you can cure the viral infection before they have advanced liver disease, patients do extremely well. What about if you take patients who have established cirrhosis or close to cirrhosis at the time that they get treated? And this is a study, again, that we did with a number of European centers, looking at what is the long-term outcome if you achieve SVR or do not achieve SVR with therapy. And you can see this is the effect on liver-related mortality, a very strongly statistically significant difference in outcome. But more importantly than that, this study was the first to really show that patients that achieved an SVR had an improved all-cause mortality. And this really, I think, was an important study because it was the first to demonstrate that this virological cure actually led to important clinical outcomes. And this is a critical point as we come to thinking about some of the new therapies I'm going to show you in a moment, and justifying the expense of some of these therapies is that this achievement of SVR, of cure, really does lead to improved clinical outcomes. Now, importantly, patients who start out with advanced fibrosis or cirrhosis, although they have an improved mortality, they still do have a reduced but still a notable increase in the risk of liver cancer over time, meaning that once patients have cirrhosis, even if the virus is eradicated, they still require long-term follow-up. And that becomes an important point when you start thinking about when to initiate therapy, because if you can cure someone before they have cirrhosis, you don't need to follow them, whereas if you cure them only once they've got cirrhosis, they still require follow-up for liver cancer. So I had titled this slide The Good News. Of course, the bad news about that slide is that it ended in 2002. And so what has happened in the meantime? Well, unlike hepatitis B, hepatitis C actually gives us a lot of potential antiviral targets. We can target the viral entry, we can target the viral protease, the viral polymerase, or one of the non-structural proteins termed NS5A. And I'll show you data supporting these targets to date. But so why has it taken so long? Why did it take from 2002 with the launching of PEG interferon until 2011 when we had the first direct-acting antivirals? And there's a few reasons for this. One is that the diversity of hepatitis C is enormous. So this actually compares, this is on the same scale, HCV, this is the 6 genotypes of hepatitis C, and you can see that if you look at the diversity of HIV, it's actually not much greater than 1 genotype of hepatitis C. And so the diversity is really enormous of hepatitis C, which has made problems for vaccine development. It also has been an issue with developing drugs because the emergence of resistance is extremely rapid with hepatitis C. The other thing is as drugs were developed, toxicity was seen in a number of the early antivirals, and it's important to remember that unlike HIV, people are rarely dying of hepatitis C very quickly, so it's not an emergency to treat people. And so our threshold for using experimental therapies in patients when the toxicity wasn't clear was much higher than it was for HIV, where you could justify saying this person really has no other option in HIV. For most of our patients with hepatitis C, at least some delay was reasonable because death is not universal and certainly not imminent in most patients. But I would argue that the real reason is actually neither of those things. This is a picture of what I would expect the HIV lobby to look like, and this is what I might think the hepatitis C lobby to look like. And I say this sort of tongue-in-cheek, but it is true that the HIV lobby has been extremely effective at encouraging government and non-governmental organizations to support research and development of drugs, and unfortunately the hepatitis C lobby has not been a very good advocate for itself. And this is not just a theory. If you look at actual real spending by the NIH in the United States, and you compare, so this is looking at the prevalence of HIV, hepatitis B, and hepatitis C. the number with undiagnosed infection, so this is a dramatic percentage of those with hepatitis C are undiagnosed, and this is billions of US dollars spent on care, prevention, and research. And you can see that HIV absolutely dwarfs the two viral hepatitides. And why is this? Well, I think it's because this is really a disease of the marginalized. If you look at, this is the prevalence in the overall US population, and then as you go to slightly more marginalized populations, African American men, hospitalized patients, those with mental illness, incarcerated people, homeless people, people who've used injection drugs, and people who've used injection drugs for a long time, you can see that the prevalence just skyrockets. And I would add immigrants and Aboriginal populations to this list of people who unfortunately have a high prevalence of infection and tend to be relatively politically inactive and poor advocates for pushing for support for this disease. But despite this, fortunately, science has been rapidly progressive, and there have been a lot of major advances with the development of protease, polymerase, and NS5A inhibitors, as well as some host inhibitors, which inhibit a viral protein, or a host protein or host factor necessary for viral replication. So if we look at what the progress has looked like, and you look at efficacy here on the y-axis and tolerability or safety, you see that when you start out with peginterferon and ribavirin, for those of you who know anything about this therapy, it's effective, or reasonably effective, but it's extremely difficult to take, with many side effects requiring injection therapy for, in most cases, at least a year of treatment. The first generation protease inhibitors, boceprevir and telaprevir, were an advance, and although they improved efficacy, they actually added side effects. So they made the tolerability of the therapy when combined with interferon lower. And the second generation direct-acting antivirals were mostly a lateral move with improved toxicity, but only a marginal benefit in efficacy. And it's only recently that we've started to move to so-called interferon-free direct-acting antiviral combination therapy, really following on the model that Professor Cooper outlined with HIV. And we really are now looking to the possibility of one pill once a day with few or no side effects with close to 100% cure rate, a drug that I like to call Perfectovir. And we are not too far away from achieving this. So this is just to show you that since 2012, there have been 17 New England Journal article papers on clinical trials in the hepatitis C realm. And this really, I think, is almost unprecedented, even perhaps by HIV, in terms of the rapidity of drug development and the amount of paradigm-changing trials in this short a time. And let me just show you a few highlight trials. I'm not going to go through all of these. One of these is combining 3 different classes of direct antivirals for hepatitis C, so very similar to the HIV early trials. And this is combining a protease inhibitor, an NS5A inhibitor, a non-nuc polymerase inhibitor, and then keeping ribavirin in the mix. And what you see are, if you remember those 50% rates with interferon, this is an astounding 96% of people in a very large trial, almost 500 patients, were able to achieve a cure with just 12 weeks of these oral therapies. And similarly, if you took patients who had previously failed therapy, the same rate of cure. So this really is 5 drugs, because this is actually a ritonavir-boosted protease inhibitor following from the HIV world, but they're co-formulated into a total of 3 pills. But this is just 12 weeks of therapy with very well-tolerated oral tablets in a sort of one-size-fits-all paradigm, and surprisingly very, very few virologic failures in these patients. And so that was with 3 different classes of drugs, but what was discovered is that perhaps you could use fewer classes of drugs if you use drugs with a higher barrier to resistance. And the nucleoside polymerase class, this is sofosbuvir, which is heralded as the lead candidate in this group, has a very high genetic barrier to resistance. And so what you see is that when you combine sofosbuvir with an NS5A inhibitor, and actually it's co-formulated in a single tablet combination, again similar to what's been done in HIV, with or without ribavirin, what you see is that with 12 weeks of this therapy, whether ribavirin is included or not, almost everybody achieves SVR. And if you take people who have previously failed therapy, including those who failed a first-generation protease inhibitor, similarly high rates of SVR with either 12 or 24 weeks of therapy. And then they pushed the envelope and said in treatment-naive patients, perhaps only 8 weeks is necessary. And you can see that, again, above 90% of people were cured with one pill once a day for as short as 8 weeks. So this is a very highly effective single tablet regimen with really no issues with resistance. And this is large numbers. This is a phase 3 registration trial, and this combination will be available in the United States later this year and hopefully in most of the rest of the world shortly thereafter. So Perfectovir really will soon be a reality. We're going to have drugs that have few or no side effects, greater than 95% cure rates without ribavirin for 6 to 12 weeks. There are data going down as short as 6 weeks with really no problems with resistance, with just one pill once a day, few or no drug interactions, and most importantly, without interferon. So this really is a major advance, and these therapies are going to be incredibly effective. So if we summarize the treatment efficacy for these infections, with hepatitis B, we have effective long-term suppressive therapy, but we lack curative therapy. Vaccination's effective, and I'll mention that a little bit later, but it's underutilized. And hepatitis C, SVR really is a cure. We've seen dramatic progress, and we're on the cusp of having interferon-free therapy with very, very high cure rates. So now the third point, that eradication or local elimination requires a lot more than good drugs. So we heard from the minister this morning that disease eradication is possible. We're all familiar with the excellent work of D.A. Henderson pushing to eradicate smallpox from the planet. And this really, I think, has given us hope that it's possible to eradicate an infectious disease from the planet. So what do you need to do for that? First of all, we need a disease that has no animal reservoir, so infections don't recur. We need to be able to treat and cure all of those who are infected, and we need to prevent all new, and I put in brackets here, chronic infections. We don't necessarily need to prevent acute infections because in this case, the example is really that chronic infection is what leads to disease. So this sounds simple enough. Let's start with the 3 components. So the animal reservoir. Hepatitis C is not found in any animals naturally. There have been rodent, equine, and canine HCV, but these are not transmissible to humans. And the only animal model for hepatitis C, which has slowed progress in this disease, is the chimp, but they do not naturally have this infection, so really an animal reservoir is not a problem. So what about treating and curing all those infected? Well, I just showed you that we have these wonder drugs that are going to treat and cure almost everybody. So what's the issue? Well, this slide really highlights a number of issues. And so what you see here on the x-axis is the diagnosis rate, and here is the treatment rate. And I just want to highlight, these are different countries, and I want to highlight a few different things. So here, you look at a country that has a relatively high diagnosis rate, so most people with the infection know they have it, and you can see that here, look at the scale here, this is still meaning that only 5%, in the best case in the world, only 5% per year of patients with the infection are getting treated. And this contrasts to countries like Australia, which actually probably leads the world in terms of the diagnosis rate, really as a testament to the excellent public health initiatives, many of them led by the Kirby Institute, to increase the diagnosis rates here. But you can see that the treatment rates are incredibly low at just 1% per year of those infected. And this contrasts to these low-income countries, Egypt, Brazil, and Turkey, who have a huge burden of disease. The size of the bubble here represents the number of people infected, with an incredibly low diagnosis rate. Almost 90% of those infected don't know about it, and a very, very low treatment rate. So this really exemplifies why this is a challenge. So why are these treatment rates so low? Well, if we look at the issues along this, these are data from the US in the non-veterans population. So this is the estimated total number of people with HCV infection in the US. You can see that it's estimated that only about 50% have been diagnosed. A smaller proportion have access to care, and if you continue down, only about 15% have been treated. That's a cumulative number, that's not per year, and a smaller percentage of those have been cured. So this should improve with these wonder drugs. We should be able to increase the cure rate, but that's not going to make a huge difference as exemplified by this study. So what this study looked at was, if you look at the proportion of the population treated compared to the burden, liver-related death, compared to no treatment. And what you see is if you double the SVR rate, you go from 40% up to 80% in the white bars, you can see that if we look at the current proportion of the population treated, we really make almost no difference at all. We really have almost no influence. And it's only when we start getting to high rates of treatment uptake that we start to see a benefit at a public health level. Looking at this another way, you can see that dramatic progress in terms of the SVR rate in the individual, getting up to close to 100%. But you can see that if you look at the actual numbers of patients treated at a population level, this really makes almost no impact at all unless we treat people. So it really makes the case that treatment uptake is actually more important than the SVR rate achieved with therapy. So why are treatment rates really so low? Well, from the patient's perspective, most of them are actually unaware of their infection. They feel perfectly well until the disease is very advanced. So most people are relatively or completely asymptomatic with HCV infection and often do not seek out medical attention for their infection. They also don't want treatment. They've heard horror stories about interferon. They're not anxious to have liver biopsies, and they're not anxious to be treated. And even once we have these perfect drugs, they still will feel that these treatments are difficult to take. Remember, I made the case that these are great, but 3 months of an oral drug is still a long time to take treatment. Think of the last time you had to take 5 days of antibiotics and how compliant you were. These people have to be perfectly compliant for 3 months of therapy, and failures in compliance lead to failures in therapy. It's not only patients, doctors as well, particularly primary care physicians, have very poor awareness of this. We did a survey in Canada and found out that 57% of our primary care providers were unaware that hepatitis C is a curable infection. We also have very few people treating this infection. Greg is one of the few infectious disease doctors that actually treats this infection in difficult and challenging populations. This has tended to be restricted to gastroenterologists, hepatologists, some ID docs, and very, very few primary care providers. We could learn a lot from HIV, where that model has been important. So now, the other issue is, of course, the payer's position, because these new drugs, with their great efficacy, are being priced really incredibly high. So this is going to create limitations on access here in most European and countries, and certainly in Canada, my home country. So this is just showing you the price of Sofosbuvir, that drug that I showed you, the nucleotide polymerase inhibitor. This is the price in the US. $84,000 for 12 weeks of therapy, so that works out to $1,000 a pill. They actually made the pill bigger than they needed to so that patients wouldn't drop their pills down the sink because of the costly loss of a pill. You can see that in Western European countries and Canada, we've been able to negotiate that price down a little bit, but you can see in contrast, what Gilead, the makers of this drug, have done is in these low-income countries and some middle-income countries with a high burden of hepatitis C, have put the cost of the drug at a fraction of the cost, just 1% of the cost seen in the US. And this is actually the estimated production cost, so they're still marking it up by about tenfold, even in the low-income countries. And this model really has worked quite well for HIV, but there's actually been a lot of pushback in the US with the pricing of this drug. This is the first time that the US government, federal government, has got involved in pricing of a drug, and very recently the Senate Finance Committee wrote a letter to the president of Gilead demanding really an explanation of why this drug is so expensive, and it's expected that there will be some continued pushback and possible legal ramifications in the US, which is really tells you how important this is. So why is it that the cost is so important? Well, the issue is with this therapy, the reason the cost is so high is it's curative therapy. It's very short-term treatment. It actually requires very minimal monitoring and arguably minimal infrastructure as well because the therapy is so well tolerated. But importantly, even if I made the case that a higher proportion than sometimes people estimate go on to develop liver disease, not everybody with HCV does develop liver disease. So unlike HIV, we don't have this impending doom for every patient with hepatitis C infection. So the challenge is that not everybody will progress, and figuring out who those patients are, perhaps we don't need to treat everybody. So right now we're in this struggle of whether we really need to treat this as a liver disease, people who have established liver disease, or to treat it as an infectious disease where we should say the presence of viremia is an indication for therapy. And that's somewhat of a debate, but I think it's not a straightforward answer. So if we think about high-income countries, they need to increase the diagnosis prevalence rate, and the US has approached this with a population screening approach by recommending that all people born between the ages of 1945 and 65, so-called baby boomers, should be screened for hepatitis C because of their higher prevalence. Arguably, we need to contain costs by treating only patients who initially have liver damage, and hopefully the access to non-invasive tools for staging liver damage, avoiding liver biopsy, will make this more accessible. But this seems like a reasonably cost-effective approach. But importantly, we also need to expand the treater pool to primary care physicians. As I showed you, the prevalence is very high in the incarcerated population. That would be a good opportunity to treat and prevent this infection. And as has been shown previously, this has been very effective in HIV. So if you think of financial models in the wealthy countries of how this is typically priced, the typical price is that you have the maximum number of dollars per pill. So this leads to very high revenue, particularly in the US, which is usually the target of the drug companies, and arguably it subsidizes the rest of the world. But the problem is that that leads to markedly lower treatment uptake elsewhere, partially because usually in even high-income countries, the price is a percentage of that targeted in the US. So a potential alternative option would be to have a lower price per pill with arguably reduced revenue in the US, but greater global uptake, possibly actually leading to similar total revenue for the pharmaceutical companies, but with much greater global benefit. Perhaps they could also think about a price per cure. And this is important because one of the downsides of having a price per pill is drug companies don't want to shorten therapy. Because if they shorten therapy, it's fewer pills, they have to increase the cost per pill to maintain their revenue. So actually a price per cure encourages shorter therapy. It's not a simple model to implement in the US because of their healthcare system structure, and people have raised concerns about adherence. If you have these costly therapies, are people allowed to have, how many kicks at the can they have before they're not able to get treatment? Another alternative, which I have proposed, is the idea of amortizing the cost of therapy over time. Because for many of these therapies, you can do a cost effectiveness model and show that these therapies are in fact cost effective. But one thing that people don't always realize with cost effectiveness is that doesn't mean cost saving. So cost effective means you get good bang for your buck, but it still costs money to save every one of those lives. And the challenge for that is that there's a huge budget impact because you've got to outlay this huge amount of money, in this case, $84,000, or in many cases more than that, for a short treatment. Now, if you think about the lifetime cost of treating someone with HIV, even with the reduced costs of the therapy, in Canada it's about $1,500 a month, $18,000 a year. You keep someone on antiretroviral therapy for 10 years, that's $180,000, over twice of what it would cost to cure someone with hepatitis C. But the difference is you've spread that cost over 10 years instead of spending it in 3 months. And that has a much greater effect on budget impact, and you can imagine that for governments trying to budget, this is really an important issue. So I'm hopeful that this is something that might be considered to try to defer or discount costs, which would lead to greater treatment uptake. And the reason this might still be attractive to industry is arguably it secures the market for them when there's less competition in the market, as there are new drugs under development. Now, if we go to the lower middle income countries, I saw this sign and I couldn't resist it, putting it in the Blue Mountains the other day, that at a cafe, push, if that doesn't work, then pull, and if that doesn't work, we're closed. And what I take from that is it's important that we don't make mistakes where we don't learn from what has come before us, so that we read the signs well and act on them quickly. And in this area, I think the HIV community has really been path blazing, and we should really learn from what they've done and not do random trial and error and make mistakes that have been previously made. So HIV really has been a major global success. HIV therapy is now available to millions in both wealthy and in resource-limited countries for many reasons. But where we have failed is in the hepatitis B field. And this is actually, I do some work in Ethiopia. This is literally a patient of mine who asked me, should I infect myself with HIV so I can get drugs for hepatitis B? And the reason for that is that under some of the regulations of PEPFAR and the Global Fund, drugs that are quite effective for hepatitis B are only allowed to be used for HIV because that's what they were designated for. And of course I understand that that's an issue, but this young woman is dying of her hepatitis B infection and has life-saving therapy in the bed next to her with someone who has HIV co-infection. So we really need to avoid this idea of partitioning of funding because we really are all on the same team in trying to improve global health outcomes. So if we think about hepatitis C in low and middle income countries, we really need to, again, increase the diagnosis rate. It's actually lower than in high income countries. And one thing we need to do is develop lower cost HCV RNA testing for both confirmation of viremia and cure, and potentially for on-treatment monitoring. We need accessible liver disease staging, potentially transient elastography or FibroScan, and serum panels. And I think an important area where Australia has really been a leader is developing national and then leading to global strategic plans for dealing with this epidemic. We clearly need drug pricing reform and consider using cheaper so-called non-Perfectovir options. But I think a strong and effective lobby can make these needs a reality. So if you think about the HIV lobby, as I mentioned, it's been extremely effective. What did it achieve? Well, it's achieved a number of things. This is the PEPFAR program in the US, which has approved a huge amount of funding. The Ryan White legislation in the US, which has made sure that in a country that doesn't provide healthcare to its citizens, they at least provide healthcare to people with HIV infection. The Bill and Melinda Gates Foundation, which has provided an enormous amount of funding, and industry, which provides funding at a low cost to many developing nations. And I would really stress the importance of industry here because they really have been instrumental. I will say it took them it took a little bit of pushing to get them to do this, but they have lowered the cost so that generic drugs now make up most of the antiretroviral therapies that are used in low-income countries. And I think we'll see this in hepatitis C, but it's critical. Now, we are starting to learn. There have been lobbying efforts from the HCV community, and this is actually starting to make some difference. So for the first time, I was very pleased to see that in 2014, the WHO has finally, for the first time, come out with an action plan for viral hepatitis in total, and they published the first guidelines for hepatitis C, and there will be WHO guidelines for hepatitis B later this year, which is arguably, it's very disappointing that it's taken this long, but it's really a great thing to see that the WHO has taken on this cause, and hopefully that will lead to a global strategy for dealing with these infections. So the last thing on my list for eradication is preventing all new infections. And so I want to mention a little bit about vaccination. So hepatitis B vaccine has really been a great success. This is data from Taiwan, these are data from Taiwan, the prevalence in 1984, and with the introduction of the vaccine here, you can see that this cohort that were all vaccinated, almost nobody with HBV infection, and that didn't just lead to lower HBV infections, but actually led to a lower rate of developing liver cancer. So this was really the first cancer vaccine, and it was really an amazing public health intervention. But there are problems. Implementation has actually been less than ideal, with coverage rates globally of less than 75%. The birth dose, which is quite important, is given to less than 50% of countries and less than 27% of neonates globally. And this is really what's necessary for global eradication. A Hep C vaccine, unfortunately, at this stage, we're not really very close. It's probably needed for true eradication. You have two options. One is true sterile immunity, prevent infection. This seems to be unlikely because even natural clearance of an initial infection does not prevent people from getting reinfected. But you may be able to impart a degree of immunity which leads to a greater likelihood of clearance when exposed. Now the problem here is it doesn't seem to be a huge appetite from industry to develop a vaccine. And then I think we can learn from the HIV world again with the idea of treatment as prevention. Unfortunately, Dr. Cohen's not going to be able to be here today, but this landmark paper, which really established treatment of prevention as an important strategy in HIV, and some modeling data which had been done by Jason Grebley and Greg Doors group looking at what would be the effect of treating patients at, in this case, injection drug users, and you can see that even with just treating a very modest number, just 4% of infection drug users annually, you can see that depending on the baseline prevalence, you can have a major reduction in terms of the overall prevalence of hepatitis C in the population. And I would again highlight that the Kirby Institute is the first place in the world to be doing a treatment as prevention trial in the prisons in New South Wales, and I would commend you for that effort. It's really a path-leading effort. And so finally, if we think about where these two strategies might be useful, the rates of new cases are critical. So if you have effective treatment may be adequate in developing countries because you can actually treat more people than get infected, but when you look in developing world countries where transmission continues to be high, you likely need a vaccine to really achieve eradication. Now, when we think about developing countries, I would say that transmission is largely through medical exposure. So this, in my opinion, is actually good news. It's something that can be really conquered by dollars. It's much easier to supply clean needles. Doctors in developing countries don't want to infect their patients. They know about good sterile technique. They simply don't have the needles. So it's still very costly, but it also has added benefits beyond hepatitis C transmission, and I think it really should be a priority. So the vision for hepatitis C in wealthy nations, hopefully we'll have broad access to Perfectovir for all of our patients relatively soon. We'll have active case finding with treatment by primary care doctors, prevent development of cirrhosis and end-stage liver disease, and prevent liver-related mortality by treating patients with cirrhosis. We'll eventually have treatment as prevention, and that might be enough, and we won't need a vaccine. In resource-limited regions, initially we'll have very limited access to the good drugs, but I think we should really focus on reducing transmission, and eradication will ultimately require a vaccine. And so to finally summarize, HCV is curable, hepatitis B is controllable, cure and control do save lives, treatment is improving at an incredibly rapid pace, and the challenges really do differ between high and low middle income countries. But as I said, eradication will require a lot more than good drugs, increased diagnosis, access to care, reduced transmission, and in the end, I think a vaccine with good implementation. And I'll thank you for your attention.